I wanted to talk this morning about one of my greatest passions, which is surgical education and the development of surgical trainees. And it's going to be a circuitous way of discussing this. But when I look at this picture, can anyone pick me out in that group? I may blend in with the crowd. This was my chief resident picture when I finished at the Mass General in 1991, so 32 years ago this spring. And when I think about how I was trained at the time, I was trained in the classic Halstedian mode. And those of you who are familiar with Halsted will know that he felt that everything we needed to be academic surgeons was going to be present within the hospital, the operating room, the wards, the laboratories. And that it's this concept that would allow us to have academic success. So I drank that Kool-Aid at the MGH. I was a visiting scientist at Biogen, and for 15 years had a funded laboratory that looked at the immunobiology of neuroblastoma. And I bought into this. But as my career evolved, I recognized that the Halstedian approach, and I'm sorry this is gone, the Halstedian approach might need to evolve a bit. And that whether we're members of the House of Surgery or the Village of Surgery, there may be other venues for us to develop our academic careers, and that we have a contract, an unbreakable contract with society in order to improve health outcomes. So, ambitious agenda. I want to talk to you about structural violence. I want to talk about toxic stress. I'm a pediatric surgeon, so we think about development. And I want to challenge you, if not inspire you, to think about ways that you can extend your work outside of the hospital. Wow. The last 3 years have been mind-blowing between the virus, the financial changes that have occurred, the racial reckoning that exists within this country, the gender recession, the first time in 50 years that women have left the market at such high levels, the social discord that threatens to divide our country, maybe even today, and a ton of other things that are going on in our environment, which I think are challenging us. Few of us can argue that these changes don't bring us to a kairos moment or a tipping point in which there are small things that have the opportunity of making big changes in who we are and what we do and how we have impact. So much of the last 3 years has brought to the fore this concept of equity. And I've often been challenged at understanding what equity means. It's one of those things, like the old quote says, you see it, when you see it, you know what it is. But putting a label on it has often been very difficult because the implications are such that we are biased and explicitly biased in a negative way. But the results are there. We see differential outcomes in people of color, in people from diverse gender identities. And these things, for those of us in surgery, we're not immune to these same outcomes. I won't belabor this very much. I'll go through these quickly. So whether in surgery, it's surgical outcomes based on race and ethnicity, based on cancer diagnosis or access to minimally invasive surgery, whether socioeconomic status, or whether it's gender or gender identity, we see differential outcomes that we, I feel, as the learned people in American surgery, should be working feverishly to obliterate. And then, particularly in a place like this, where you clearly are among the best and the brightest. Well, many of you, particularly those of you who are younger, are familiar with this graph or this concept of the social determinants of health, where we live, where we work, where we play, where we worship, has a tremendous impact on healthcare. And when I come to a place like Palo Alto, I look at you as being really at the top of the mountain, because many of these issues do not seem, as an outsider, to weigh heavily on your patient outcomes. But for people like me who practice in major urban arenas, our population suffers under this weight tremendously. And although we think that advancing surgical outcomes, medical outcomes exist in this realm of doing advanced surgical procedures, cloning genes, developing tumor vaccines as we did, those outcomes are only about 20% of the overall ability to have impact. And you know, the classic health outcomes are premature death, disability, and disease. Those are the classic ones that the IHI states. But you know, I recognize what's been noted here for more than 2 decades is that much of the avoidable mortality lies in these upper quadrants. And as you know, our zip code is more important than our genetic code. So, you know, this, when I've had this talk over the years, people say, yeah, Ed, but this doesn't really relate to surgery. But Tracy Deckard, who some of you may know from Boston University, and her colleagues, her resident, Megan Janeway was a medical student, now a resident, have put together this format that is very well detailed in their article from last spring that looks at the interrelationship between social, healthcare, and physician factors and patient factors in creating these outcomes. And as I've mentioned to you, these health outcomes are classically considered premature death, disability, and disease. And that we as physicians may embrace what's known as cultural competence, a term I absolutely hate. I prefer the term cultural humility. And as we embrace that and understand that the fourth driver of health outcomes, which I want you to remember, is despair. And I think that despair is one that drives so many of the others. And that we as surgeons have an opportunity of impacting health outcomes, again, through creative ways. It's always amazing when your student becomes your teacher. And this saying from Adam Grant, who's one of my favorite writers, who challenges us always to think again, is that the great teachers introduce us to new ways of thinking. And so in 2006, I was going through, maybe it was a midlife crisis or a career crisis, in which I did not get my NIH funding for my lab. I was sitting in a lobby at the Four Seasons in Philadelphia about to give the boards, and I bumped into an old friend, Paul Farmer, who had been my medical student. And there was a thing at the MGH called minor surgery, and Paul was a third-year medical student. I was a second-year resident. We spent 24 hours together for about 3 weeks every other night, and we got to know each other well and to become friends. And unfortunately, we lost Paul last year, but what an incredible thinker, what an incredible teacher. And what Paul challenged me as I was bemoaning the fact that I didn't get funded. He said, Ed, you know, you've been looking at way too much molecular stuff alone. He said, you know, why don't you come to Haiti with me? I said, no, I don't think so. There's a lot of work to do in Pittsburgh. He said, so let's think about this. You know, let's not go molecular as you're planning the next step of your career. Think about what might be the biosocial means of you having an impact. And so this was a very critical conversation for me. And it led me to make the decision to leave Pittsburgh, where I was a tenured faculty, tenured professor of surgery, and to move to Cleveland, to move from what I felt was academic success to social significance. And so I want to ask you, and I'm focusing mostly on the younger people in the audience, the people who I presume are residents or young faculty, but I also challenge the senior people who are here in the office, here in the audience. Who are we? What is your identity? And do we have a social responsibility as surgeons? And so someone might say, I don't know. But I think that we do. And I think that we must think that we have a variety of capacities in which we can impact society, impact health outcomes through these various activities of what I would loosely call advocacy. Well, people like Thomas Huddle, who is a medical ethicist, says, Ed, absolutely not. He said that physicians should steadfastly resist. He says that, one, we're not trained, two, our opinion really doesn't matter, and there's so much of a growth of information that exists that we should be focused on refining our abilities as clinicians and scientists and practitioners. And I guess that many of us globally feel the same way, because less than 50% of surgeons participate in any form of advocacy. And advocacy doesn't just mean in the realm of social justice, but less than 40% of surgeons vote. And so I'm fond of the saying that, if you're not at the table, then you're on the menu. And I think that we have allowed ourselves, because our lack of personal advocacy or agency in the realm of advocacy, to see ourselves as advocates. Although some of the recent data is suggesting that there may be gender differences among us as to who of us see ourselves as advocates. So this concept of the physician as advocate is not something new. It is not something that is millennial. In fact, Rudy Virchow, Dr. Rudolf Virchow, working in the mid-1800s, had a newspaper in which he regularly published on social medicine topics. It didn't last very long, but he saw that physicians were the natural advocates or attorneys of the poor. And many of us, when you say physician and attorney, we don't necessarily think favorably of attorneys, but I like to throw in the term advocate there, because I truly believe that we are those natural advocates. For this august and insightful group, I don't have to define advocacy, but if anyone doesn't understand what it is, I think it is diverse. It is a diverse interpretation of the word. And each of us has an opportunity to think about those things that we can raise our hand, that we can tweet, that we can impact the status quo, to make the status quo better. And I think one of the things that you learn if you live in this part of the country is that the great success that has occurred in Silicon Valley is the concept of iteration. You build something, or you think about something, you build it again, you revise it, you get input. And this concept that has emerged for surgeons, in particular, in response to the gun violence crisis, to stay in your lane, I think has been a bit negative for us. But there are individuals such as Heather Levy, a surgery resident at Oklahoma, who I'm proud to say is going to be going into pediatric surgery, and I think she's in the match this year. She published a paper in which she looked at groups across the country. And in fact, as this animation goes away, she did an anonymous survey of 3 institutions, 46% response rate, almost 50-50 faculty and trainees. And the bottom line is that she found in her study, and this was published in the Journal of Surgery, that most surgeons believe that they should be involved in advocacy, and actually more women than men, 86 to 64% believe this. And I think this is a powerful paper suggesting that, one, younger surgeons and female surgeons are leading the way in this area of advocacy. But there are the people who said that they did not want to participate, make valid observations. They say that, it's their personal choice not to. They're concerned that it will be viewed as not being professional, and that it may interfere with their in-hospital relationships that may prevent them from getting academic promotion or raises, or their patient relationships. I think all of those are valid. But I likewise think that, I'm somewhat libertarian in my views about individual freedoms. I think we all have the ability to choose how we want to show up. But I think that this concept that we have to stay in a particular lane is not appropriate. The worst thing that you can have as a speaker is what I'm going to do now. It's almost like me standing in front of you talking about my children. And so I'm that guy. So I want to talk about one of my professional children. This is Dr. Ayla Stanford, who's a pediatric surgeon in Philadelphia. She's now the undersecretary of one of the undersecretaries of Health and Human Services. But I met her when she was a surgery resident who was getting bumped out of her program, and she came to Pittsburgh to work with my best friend, Henri Ford, in his laboratory. And since 2001, I've been her mentor. She's been my protege, in a non-pejorative way, my professional daughter, and one day my professional CEO or boss. So, but what Ayla did is what I would challenge everyone to think of doing. So when the pandemic broke 3 years ago, she's a practicing pediatric surgeon in private practice in Philadelphia. And she's from Philly, and she saw the devastation in her community. So she left her practice and she started testing people in the streets of Philadelphia. She rented a van, she ultimately bought a van. And in fact, in the early stages of the pandemic, beginning about April 1st until June, she had tested more people in Philadelphia than any one healthcare system. She put this on her back. And then she ultimately started vaccinating people, and this led to her having multiple appearances on CNN, the national media, and becoming close with Anthony Fauci. She was named one of Forbes 50 under 50. And in her CNN, one of the 9 CNN heroes for 2020, Anthony Fauci gave an incredible introduction to her. And so the point is that this is an opportunity for us to take our surgical skills, to take our ability to focus, and to take what we do to have impact and move outside of the laboratory, outside of the hospital or clinic to improve society. So I emphasize that this can be done. And, again, the chauvinism that I have, I'm going to show another pediatric surgeon, Pete Maziakos at the Mass General, who is chief of trauma, pediatric trauma, who's done everything from working with the former governor of Massachusetts to institute changes in ATV and the use of bike helmets, to walking the streets of Boston in peace rallies, to getting Peter Slavin, the CEO, to give $1.5 million to establish a gun violence prevention center. So it can be done. And I think that as we think about our abilities to move the needle, there are many ways that we can approach it. So I'm sure there are people who are in the audience saying, okay, Ed, what are you saying? Are you saying should we have advocacy and activism training within surgery? I say absolutely yes. And getting back to Tracy Deckert, those of you who are familiar with her and her work will recognize that she's established this program, the socially responsible surgery approach. And so this is one that is not just about urban social responsibility. In fact, much of her work looks at global responsibility. But the template that they use for the educational program is one that's based on advocacy, education, and I feel a very strong, important part of doing this is having research, which provides the data and the evidence that the efforts that you're doing are not just charity, but are based upon equity and science. And so this is the format, the framework that she has established at BU, and I know that at UC Davis, there's a similar program. You may have a program here, but I feel very strongly that every surgery program should begin to think about having an advocacy track and developing a curriculum similar to their CARES curriculum, which has that acronym that you see there is clinician, advocate, researcher, educator, and service leadership. And so Pat Donahoe, who's been mentioned twice, told me, Ed, in your career, always follow the science. And I began as an academic surgeon, and I was following the science of malignancy and tumor-induced immunodeficiency and enhancing the immune system. And I recognized that now I'm following the science, but the social science. And so what I'd like to do now is to talk to you about my work in this area. And you've seen some of the influences that kind of brought me from a point of being a laboratory scientist to someone who is, if you will, a field scientist, looking at trying to change the narrative for an important group of people in this country. And that important group for me are children. Gun violence is the leading cause of death, children across the country. So it's unclear to me if I have to make the argument to this group that gun violence is a public health issue. In some venues that I've spoken in, people will say, no, it's a public safety issue. But I would like to argue strongly that is a public health issue. And if you don't feel that, then you must be living under a rock. These are the things that we see in the media that are showing us that we are looking at a pandemic of violence in our country that is impacting children and young adults in a major way. And as someone who grew up in a home where there was several guns, both my father and my mother had one, and my father was away a lot, and my mother had a gun on her nightstand every night because she was afraid that someone would break into our house. I'm not someone who owns a gun, but I recognize that there's a Second Amendment, and I honor that for those people who feel that that's important. But regardless, we've seen a tremendous increase in gun deaths. That's just then, 2020. In 2021 and 2022, that number has increased so significantly. And in places like Cleveland, we are in what I call a syndemic. And a syndemic is when two epidemics coexist, and the presence of those two accentuates or exacerbates the burden of disease. And so we're seeing a violent syndemic. Those of you in pediatric surgery or those of you in trauma are familiar with this article that came out in April in the New England Journal, which showed us that beginning in 2019, that more children were dying from firearms than from any of the other causes of death in the country. And when you look at this, some people will look at this with a sense of despair. I look at this graph with a sense of great hope. And you might say, well, that makes no sense. So how do you see hope in that data? Well, 20 years ago, kids were dying from automobile injuries. But the work to ensure car seat safety, to ensure airbags and education made a tremendous impact on that mortality. I think that a similar type of public health effort, education and awareness, can have that same impact in gun violence. We didn't take automobiles away from people, but we did things that would enhance safety and improve the overall prognosis. So for me, 2007, as you heard, was the year that 2006, I became promoted to professor with tenure at Pitt. In 2007, I moved to Pittsburgh. And I was excited. I mean, for many of us who aspire to have leadership roles in academic surgery, for me, it was a dream come true. A small town kid, neither parents went to college. My mother never graduated high school. This was great. But my very first patient was a patient who was killed as a result of gun violence. He was walking to his aunt's house. And I realized that in so many ways that my dream was a bit shattered. And I didn't understand the depths of the social determinants in Cleveland as they impacted children as I did once I got there. Highest child poverty rate of any city year over year. Highest infant mortality rate year over year. The highest suicide rate within the public school system, inner city school system. And it was in 2011 that the crossover occurred in Cleveland, in which more kids died as a result of homicide, all causes, than all the other causes put together, which made me recognize that there was something going on beyond the obvious. There's also, back to the social determinants of health, a difference in overall mortality for the community. The Cleveland Clinic and University Hospital is located in a neighborhood called Huff. And this is a classic inner city neighborhood that has suffered from urban blight. A child there, born in 2007, according to HBO's special, born in 2007 in Huff, which is probably one of the best places in the world to have a TIA or chest pain because you can get immediate care from two great centers. And a child 8 miles away where the Whole Food is, the life expectancy is 24 years. And this seemed really unacceptable to me. And so as a guy who moved to Cleveland to kind of recharge my academic career, as much as I tried tight walking my way away from these problems toward academic medicine, I kept getting drawn into them. And so I realized what I needed to do was run to the fire and to figure out a strategy of trying to address these issues. And I recognize that many of these issues that we look at are the result of violence and trauma that exists within the community. One of my kind of favorite writers and people, Brian Stevenson, who I badgered last year, his secretary over and over again. He only does 4 public speaking engagements a year. And he came when I was president of APSA to do one of my presidential addresses, had often said that if you want to have impact, that you've got to get close to the problem. And he says it in a different way, but I think that's whether you're a scientist in a lab or whether you're trying to do things in the community. So what I did, I got angry about what I was seeing. I went into the office of the president of our hospital and I said, what are you going to do about these problems? And he stepped back at me as any great leader would. And he said, Ed, what are you going to do about the problem? And so what I did is I asked him, can you set up a meeting with the mayor of Cleveland and the chief of police of Cleveland? And we established this program within 6 months called Operation Focus, which is a tough love program. We brought all of these under 18 kids who had shot people, who had outstanding warrants in. We'd go to their neighborhoods. I actually would go into crack houses. I'd go with the SWAT team and meet the gang leaders. I don't know what was on my mind at that time. I did some things that nothing illegal, but I went into places and met people that I couldn't imagine. I also went into churches, the juvenile detention center, the rec centers, so that I could get proximate to the problem. And we established this tough love program. We told the kids that we met at these call-ins, if you don't change your life, we're going to send you to prison in Leavenworth, where you'll be the bait for people who are looking for young men to come in. And lo and behold, these efforts resulted in the lowest murder rate in the 50-year history of Cleveland. And we were proud. It was a multiple group. We brought mothers who had lost children. We brought former gang members, people who'd been in prison. And we parlayed this into a Defending Childhood Initiative grant that garnered us $2 million. And the thing that I've learned is that once you get something, you have to avoid the temptation that you think you have arrived. So once the money ran out, and here's Eric Holger, who came to give us the money, and those of you who are familiar with my friend Steve Dettelbach, who we worked on this grant together, he's now the head of alcohol, tobacco, and firearms. We felt we had established programs, but what happened is the money ran out and the violence went higher than it had ever been. But what I learned from these times of going into the community, getting proximate to the problem and talking to young kids, I learned this term that they called life to me. They said what life is living in fear every day. And the vast majority of the kids I saw never felt they would live to be more than 25 years of age. And so in my mind, I began thinking about how I could get rid of this despair and how through corporate efforts with other people that we could give oxygen to hope. So I saw so many young boys, mostly African-American boys, like these two brothers, who had seen things that I could never imagine seeing at their age. And for many of the children in urban Cleveland, childhood was blurred, and that their ability to dream futures such as I was able to dream was impaired by the level of violence they saw and the trauma that they experienced in the world. And by the time that we saw many of them in the emergency room, in the pre-op holding area, or in our clinics, many of the children were really suffering from having fallen down the steps of the social determinants of health. And as I mentioned, many of these children had seen things or experienced things that had had a tremendous impact, not just on their brains and not just on their perspectives, but this level of trauma that they saw also impacted. This level of trauma that they saw also impacted their body. And what we recognize is that severe trauma also takes its toll on physiologic functions. And in so many ways, the body keeps score. As one of my professors at Harvard Medical School 40 years ago, Bessel van der Kolk, has written so eloquently about. And so some of the children, if they're not direct victims of violence, become bystanders of violence. And you guys probably know this study well, done at Kaiser Permanente. I think this is such an important study in medicine. This is called the ACEs study. And they looked at about 17,000 people in Southern California, mostly non-minority, educated, and they evaluated household dysfunction among this group of people. And what they found, whether it was household dysfunction, abuse, or neglect, that there was a significant number of the population, 2/3 of the population, that had at least one. And your number of ACEs correlates with your overall survival. And if you have more than 6 ACEs, your survival is cut 20 years. And it may be changes in your behaviors, such as an increased use of tobacco, alcohol, or illicit drugs. But these ACEs really result in a degradation in your overall health. So through the work that we did in the community and I'm still operating as a surgeon, I came to recognize, and I have to change the slide from greater exposure to violence, but it's greater exposure to violence, both direct and indirect, and the sequelae of the trauma that gets embedded that has a tremendous impact on health. And we classically, as I've mentioned over and over again, the classic health outcomes are disability, disease, and premature death. But in my experience, I found that the most important health outcome that we can impact through our work that becomes focused on equity and meeting people where they are is the need to address despair. And that's something that many of us are reluctant to do. And this gets to the point of structural violence. And so within our healthcare systems, our hospitals, our schools, deeply embedded in those is a level of indifference or inaction to a group of patients or a group of people that allows this problem to fester. And as Paul Farmer emphasized in much of his work, both international and talking about the national status, he felt that this structural violence causes injury and it keeps people from aspiring to the dreams that they have or getting access to those things that can pull them up. First week of October, last week of September, first week of October in 2015, I had one of the worst weeks of my life. Those of you who listen to the podcast called Serial will know the story of that beautiful angel there. She was sitting in a car waiting for her mother to get candles for her father's birthday. And what happens now and why I don't go into the streets anymore is that, 16-year-old, 17-year-olds were shooting at each other across the street. And the guns are heavy, they're poor aims, and she was shot. I'll always remember the size of a 6-month-old's heart, which is about this size, the size of a plum. We did everything we could. We opened her chest and we could not get her back. And the most difficult, it's almost painful to talk about, the most difficult part of this was not just telling her mother, but when I was telling her mother that they'd lost their 6-month-old, her 8-year-old sister was sitting, shaking, covered with her sister's blood. And I realized at that point that something had to be done, and something had to be done by me. This boy is graduating high school. There's another child. So these kids were all under the age of 10, except him. He was 11, and 4 of them died. He lived, but he had a brachial plexus injury. His father, who was a drug dealer, was shot in the head, and the bullet was embedded in his brachial plexus. So what did we do? So with a medical student who is now a second-year resident here in pediatrics, we looked over the next 2 years at the gunshot wounds and the injuries that we saw. We see about 70 gunshot wounds a year. And what we found, and we looked at assault, we looked at all violence. We found that 30% of our gunshot wounds, now mind you, 6 to 15 is the ages that we take care of. 30% of those kids would be back within 2 years with another gunshot wound. And then another 30% would be back with an episode of severe depression or suicide. For me, unconscionable. Not just unconscionable, but moral injury. And so much was going through my head. I couldn't figure out what would be a strategy. And so we began to collaborate. So we have a remarkable big database at Case Western, only one of 6 in the country. It has about 250 million entries for now, it's about 300 million for 700,000 children who have been born in the county that Cleveland exists. It's called a child database. It's a longitudinal database that follows children, everyone born from 1989 until they die. And it's a fascinating database because it captures these domains for everyone, regardless of the neighborhood that they exist in. And through AI and big data, they're able to create profiles of who these children are and what may be risk factors for such things as hypertension or for dropping out of school. So we had this idea, could we look at our trauma patients using this database? So I want to try to run through this quickly, and I'm happy the reference is listed there. So in Cleveland, about 93% of the gun violence and physical violence we see is African-American youth, both male and female. So we took their records. Let me just show you this slide. So we asked the question, who are these children? And we wanted to look at adversity within this group. This may break it down better for you. 6 to 15 years of age, that's what we see in our institution. We had 452 patients, individual patients. We excluded 5. They were not from Cuyahoga County. That's 447. And we found that 429 of those kids were in the database. That's all trauma. We divided the group between assault victims and gunshot wound victims, 2 categories. And we compared them to age-matched controls, 20,000 age-matched controls from the same zip codes, same neighborhoods, in order to stratify and understand the populations. Crazy slide, too many words, too much color. But what we found were 2 important things. That the kids who were, the controls were a distinct group of kids, same neighborhoods, same housing projects. The kids who were more likely to be shot or more likely to be physically assaulted, both had these issues. They were more likely to be preemies by birth, more likely to have child welfare contact, need public assistance, housing insecurity, food insecurity. The gunshot wounds were in an even greater category of significance, and truancy was a big factor. But all of these pointed to early household dysfunction with their mothers. We found that although their mothers averaged 16 years of age at the time of their birth, the mothers themselves had much greater trauma. And this slide, again, rushing through this quickly to get to the end, is that we found that of the 452 patients we saw, only 12 had never had any involvement with any of the child welfare services at all. And so again, we recognize that this concept of trauma, of treat 'em and street 'em, just is not at the benefit of children. And that what I argue is that We can't just provide clinical care. We have to develop an ecosystem of care that prevents this from occurring again, recidivism, or prevents it from occurring ever. Margaret Mead, the famous anthropologist, was asked once by a student, what was the first sign of human civilization? And she responded, a healed femur. And so the student looked quizzically at her. Why do you say that? She said that a healed femur meant that someone had to stick or stay with this person until it was healed, to care for them. Otherwise, a wild animal or the person would starve. And so as I thought about this concept, I remembered something my grandmother, who of all things was fluent in German, she was born 1886, and spoke French. She would never explain why, but she was a social worker. And she would use this term in French, an accompagnateur. And so these words of my grandmother of being an accompagnateur, or one who goes along with, this concept of broken bones, helped me realize that I needed to change my approach to gun violence from the vector, the guns, to the victim. And so as I thought about my own life, and as I thought about the things that I had seen, and not in my home, but in my community, I recognized that many of these kids were broken. And that what we needed to do is to figure out a program that we could be an accompagnateur. And as a trauma surgeon, I had always heard this term that hurt people hurt people. Didn't really make a lot of sense to me until I started immersing myself in this work. And as a trauma surgeon, once you recognize that a patient is injured and that they can be fixed of their trauma, I recognize that if hurt people hurt people, we have to change our language of violence from one of understanding that this is not moral deficiency, but it's a condition that they can respond, as my good friend John Rich says. And so if as a surgeon, a trauma surgeon for kids, I'm a healer, then certainly healed people can heal people. So I wanted to move from having work in the trauma bay and the operating room, which is downstream, to think about how we could move upstream and how I could develop a program that might have impact on kids and then influence policymakers in order to change the way we look at things. I use this concept of human-centered design, something that I had studied for a long time, and I took all my moleskins. I'm fanatic about taking notes that I had acquired from my other programs. And we developed a model, and I developed this model with the resident who's here, and over 2 years, we developed a program. And we use, I'll just go through this, a theory of change model. I won't talk about that, but I will talk about the bottom, is that we wanted to create a program that would move children from hurt to heal to hope to whole, create a sense of wholeness. There's a concept known as antifragility. It's a business concept promoted by Nassim Taleb, a business professor at NYU. I read the book in the early 2000s, and he states that companies that go through severe distress, that are broken and put back together again, are stronger than those that don't go through any chaos. And you know this, so you think about this. This is a goblet, you drop it on the floor, it's fragile, it breaks, you can't put it together. This is a sword, it's robust, it can't be bent. There are a few things that can't be broken. But DNA is one of those things that when you break it, you put it back together again. It's stronger than it was before. And it reminded me of something I always wanted to be as a kid, and that was someone who worked in ceramics, of an art form that I was always fond of, which is called kintsugi. And this is the art form of golden repair. You may be familiar with this type of ceramic. There was a Japanese shogun in the 16th century who dropped his favorite teapot. It broke. He went all around the country and he couldn't find anyone to fix it. And there was one artisan who fixed it by using liquid gold to put it together. And it became more beautiful and more valuable. And I know it seems really arrogant, but I wanted to develop that program to take these kids who are broken and to go upstream and create, make them anti-fragile, to make them stronger in the broken places. So this is the program we built, the logo we developed. And so these are the core values of our program, our Antifragility Initiative: community, equity, prevention, opportunity, care. And I hope that what I've done is help you understand how we got to this program. These were our specific aims. We wanted to keep the kids from getting injured again, and we wanted to prevent them from retaliating. You know, the biggest risk factor to being a shooter is having been shot. We wanted to go upstream. We wanted to look at those things that were creating stress in the community. We wanted to improve their life performances, and we also wanted to avoid hospital members re-traumatizing them. This is our summary. We are a person-centered, holistic case management program that lasts for a year for children from 6 to 15. And these are the words for those of you who think in terms of words. I think in terms of pictures. And so this is our infographic of our program. Patient hits the emergency room, and we're modeled after the adult HVIP programs. Patient hits the emergency room, and once they're stabilized, there's a teachable moment. There's a time when our social workers converge on them. We meet them, and within 48 hours of leaving the hospital, we are on the phone with them, and within a month, we're in their home. Health care occurs in the hospital. Health occurs in the community. We are a health program, and I believe that in order to promote health, we have to be in the community. Well, you know, we had this great idea, but we didn't get it funded. A hospital didn't fund it. And this is Michael DeWine, who was the Attorney General, and who is a very right-wing conservative Republican. He came to our town to talk about ending gun violence in 2018, and I was there to speak, and they never let me speak. I'm a pediatric surgeon. It's not as important as adult people. As he was leaving, I said, Mr. DeWine, I have something to ask you about, tell you about. He said, I don't have any time for you. I asked him again. He said, doctor, I said, I have no time for you. And he beckoned his security people. So I just kept talking. And 30 minutes later, he said, that's a good idea. I can't talk to you anymore, but can I call you? And in essence, he gave us just under $700,000, and we've gotten a total of $3 million from the state for our program. Not going to go through much with how we set up the program, but these are the stages that we established. We were somewhat interrupted by the pandemic, but again, we've got 3.2 million funding, and we have another million that is pending next week from the city of Cleveland. The mayor was so intrigued by our program and our results that he put it as a line item in his budget. Michael DeWine said this was the most innovative social program that he'd seen in his tenure as Attorney General and now Governor. We improve access to care. We become a medical home for our patients. We've seen a total of 15, these are the families, but a total of 1,555 individuals we've cared for in the last 4 years. We provide 300 meals a weekend, and we collaborate broadly across the community. We're trying to create a trauma-informed hospital by having periodic training sessions to help people understand these components of trauma-informed care. And also I established a program, seminar program at the medical school at Case Western for medical students, about 25 a year, in which you see these people who've come to Cleveland to participate in. And I've funded this through my Endowed chair, and it has been helpful. This resulted in an invitation to the White House this summer. I'm the old guy on the end. So I leave you with this concept, and particularly to Stanford. Stay in your lane? Absolutely not. When I read the things that you talk about in your program, the future of surgery, inventing the future of surgery, Dr. Hahn, how could it be more inspiring than that? You are inventing the future of surgery. And I think that does not just occur in the test tube or in the laboratory. It may occur in East Oakland. It may occur in Turkey. And so as you think outside of the institution, I think you have an opportunity to have tremendous impact. And how do you do that? I think you got to lean in. And you got to think about your social responsibility. We need to educate the trainees and educate ourselves in how we do this. I don't have to tell people in this part of the country about the importance of innovation, but I think human-centered design programs are key. We've got to be self-educated, we've got to collaborate, we've got to construct, iterate, and we also have to develop some degree of scientific rigor. So as I close, if we're to produce the surgeons of the highest caliber, then I think we may need to have an amalgamation of this Halstead view and this Bridian view, in which we recognize that we have an unbreakable contract with society, and that the promise of surgeons as leader in the community has been there forever. I so appreciate the opportunity to come to California and to unfortunately end right on time, but I thank you for listening. And I leave you with this concept that we should not be just against disease, but for justice. Thank you so much.